meet everybody. I usually do this in person, so this is our first time trying this, so excuse any hiccups. Usually I give a talk on breast reconstruction, and this talk really is designed to educate you guys, everybody out there, about the different options available to you when it comes to breast reconstruction. And we're not just talking about mastectomies, we're talking about lumpectomies and various different aspects of breast cancer treatments. And it's important to know these options beforehand. Now, a lot of us may have already gone through or it might be in the middle of something, and it's never too late to learn and know your options. But the goal is to try to get that information out there as much as possible so that you can make the best decision moving forward, because it's a long process, multiple steps, and it's best to be educated. It helps with the anxiety of everything as well at the same time. So let's just go ahead and get started. I always like to people ask, what is exactly breast reconstruction? What does it do? Well, it's a general goal. Breast reconstruction could be one of many different procedures, but the main goal of breast reconstruction is to really restore the appearance of the breast that's been affected by a breast cancer procedure or some sort of breast cancer surgery, like a lumpectomy or a mastectomy. And it can involve one or both breasts. And it's really, the reason we're really doing it is to make you feel whole again. It's not a life-saving procedure. It's a life-changing procedure. It's a mental thing more than anything else. So that's why we do it. And it's very important for that very reason itself. In fact, in the 1990s, the Congress passed a legislation that said basically when insurance companies choose to cover breast cancer procedures, they need to cover all aspects of breast cancer procedures, and therefore breast reconstruction became almost a mandated thing when it comes to your care. So if folks have heard that maybe breast reconstruction is not covered by insurance now or later on, it's just generally not true. It doesn't matter if you're currently going through breast reconstruction, have had reconstruction, but need corrections. Those are still typically covered by insurance. And over time, as people learn more about breast reconstruction, the number of people getting breast reconstruction continues to rise. But as you can see, for example, in that 2007 number, in that publication, the more you know about breast reconstruction, the more likely you are to have it. In the Washington, D.C. area, I know a lot of the folks out there who do breast reconstruction, and they do a very good job of getting that message out there. And so there's a high number of breast reconstruction patients relatively in that area, which is in perhaps other parts of the area where there's not great education regarding breast reconstruction options. So it's really important that we know everything we can going into it. And like I said, you want to know your options, right? Right now, less than half of women who actually require mastectomy are offered breast reconstruction surgery. That seems maybe different to the numbers that you just saw, but those were people who actually were offered breast reconstruction choosing to get it. This is, in general, those who actually require mastectomy, less than half are actually offered breast reconstruction surgery, and 20% of them really elect to go immediate reconstruction. That means reconstruction right after you had the mastectomy portion. So it's really important that we get those numbers up, because I think ultimately it's going to make a huge difference in both how the results that you get in terms of how good the reconstruction looks, as well as how it makes people feel and go through that process mentally. When you are looking at breast reconstruction, when you're looking at what are your options, you really want to look at what's important to you. You have to prioritize that. Right? So you have to ask yourself some questions, and you have to dig deep and understand that. How will the loss of breast affect the way I feel? Like how is me potentially losing my breast going to feel? I can tell you, I've spoken to some women who truly, they tend to be older, but they truly feel that removing their breasts is not going to affect their quality of life at all. And they have elected to not have breast reconstruction. And that is completely a personal choice. And if that's how they feel, great. They can move on faster and not worry about a reconstruction phase. But for many folks, especially younger folks, they want to kind of feel whole again. And so you really have to think, how is this going to make me feel? Will your diagnosis or treatment impact your reconstruction options? That's a really complicated question that's hard to answer by yourself. you need to ask both your plastic surgeon as well as your breast surgeon and oncologist, because ultimately, a lot of folks that get lumpectomies or mastectomies need additional treatments like radiation or chemotherapy. And if you're getting any one of those treatments or the combination, that can affect what kind of reconstruction might be best for you and when the reconstruction can actually happen. So it's important to know those things going into it. The timing of the reconstruction could affect your decision, meaning if things are not good right now for you to go through a prolonged process. Some folks decide to not have reconstruction when they have their mastectomy, and that is an option. It does change the types of reconstruction that you can do later, but it doesn't mean you can't get a reconstruction. It doesn't mean you can't get a good option. And I'll show you folks who have had what we call delayed reconstructions, getting their reconstructions done at a later time after their mastectomy, months, maybe years after. Again, you also understand, talking to your plastic surgeon, how do you feel about having a reconstructed breast? As you can see later on, a lot of breasts will look very natural. Some will look not as natural, but they will look good. Just like some breast augmentation patients don't look quite natural. But it's important for you to recognize what is feasible and what it's not, and what a breast reconstructed breast looks like, and kind of also be aware of that when making your decision. Know that mastectomy removes the breast tissue and sometimes the breast skin. That process removes all the nerves and nerve fibers and sensation that you had to your breast. So even if you get a very nice looking breast reconstruction, you likely won't have the same level of sensation, even close to what you had before surgery. So just be aware of that. And some women have very large breasts before their mastectomy. Some women have very small breasts. To a certain degree, you will be able to resize your breasts during that reconstruction. So that's something to think about as well. And your lifestyle can be affected based on the recovery time needed, based on the type of reconstruction you choose. And we'll go into what reconstructions maybe will have a greater upfront cost in terms of recovery, which ones will get you back to doing your normal activities faster, but which ones may require more procedures down the road. We'll talk a little bit more about that as we dive into the different options for breast reconstruction. So at the end of the day, how do you choose which breast reconstruction is right for you? You really have to look at your health and personal considerations. You have to think about what type of cancer surgery you're having, lumpectomy versus mastectomy. Those will change your reconstruction options. As I mentioned earlier, the need for radiation therapy or chemotherapy could affect your ability and timing for reconstruction. Immediate versus delayed, as we touched on that. And again, the recovery time. Some people just need to get back to being themselves faster, and that could affect which options they choose. So all of these will be important considerations when you choose which post-mastectomy reconstruction option is best for you. One of the most simple, and perhaps the most simple option, is to not have reconstruction at all. And that's fine. Like I said, I know women who have chosen that, and they're very okay with it. I know one particular lady who elected to not have reconstruction. It was on her right side, and she was an avid tennis player, and she loved it. She actually loved the fact that now her breasts, which were formerly very large, weren't getting in the way of her tennis game. So for some people, not having a reconstruction is a good option. But for most people that I've met, they want some sort of option in addition to that. And if your breast surgeon as well as your cancer surgeon tell you that perhaps reconstruction immediately is not the best option, a intermediate sometimes is actually a breast prosthesis. These are typically made out of silicone. They can have a nipple or areola complex that's on that prosthetic as well. Tends to fit under a bra or under clothes. So you have that similar contour, a matching contour to your other side. That's a good option as a bridge, or potentially a long-term option if you don't want to have reconstruction at all. But most women end up getting some sort of breast surgery, and breast surgeries can vary. And when I say breast surgery, I'm not talking about breast reconstruction. I'm talking about cancer surgery, So oncologic breast surgery. And most people call it breast conservation surgery because they've stepped away from the old days of removing a lot of skin and a lot of tissues that didn't need to be removed. But there's still a wide range of what you can get. There's the lumpectomy, or a limited mastectomy in some cases people call it. But a lumpectomy is really where they just remove a portion of your breast tissue that includes the mass or cancer and some of the tissue around it, some of the healthy tissue around it. In nearly 100% of those cases, however, you will require radiation afterwards. That's something that's required. And we'll talk about how radiation can affect your aesthetics and the shape of your reconstructed breast down the road. So radiation is definitely one of those considerations that plastic surgeons really dread sometimes, because radiation can affect how your breast shape changes over time. Just to touch base, just to kind of give you a preview, radiation can shrink the breast, it can reduce the volume of the breast, it could increase scarring in the breast, it can also create indentations along the breast, and there are different things we can do to help improve that, and I'll show you pictures of that later. A lot of women will actually get mastectomies. This is an option that's usually given to a patient that has invasive cancer, and it may or may not require chemotherapy or radiation afterwards. And those are, again, separate considerations. Mastectomies these days are really kind of lumped into two different kinds. You have your non-nipple sparing, or we call skin sparing mastectomies, and nipple sparing mastectomies. With skin sparing mastectomies, typically the nipple and the areola, along with perhaps a little bit of skin, is removed, and most of the skin is left behind. But there is what we call a decrease or paucity of skin, and for that there are certain things we need to do to kind of stretch the skin out, and we'll talk about that in a second. For nipple sparing mastectomy, there really is no removal of the nipple or skin. You basically are left with the entire pocket of the breast that you started out with, except that internally the breast tissue has been removed. And that tends to give a more natural shape and a better appearance to your reconstruction, but it's not always an option for folks. And that's something you need to talk to your breast oncology surgeon about, whether you are a candidate for nipple sparing reconstruction. Personally, if I could have every patient be a nipple sparing patient, I'd prefer that, but that's not always possible based on the size of their tumor, the location of the tumor, various different things. And so you need to talk to your breast oncology surgeon to know if you're a good candidate for that. So what we're here for is reconstructive options. What are our reconstructive options? And Tally, if you start seeing any text or chats coming in, just let me know. In my current view, I don't see my chat, so there's one
person did comment asking about capsular contracture.
Great. We'll talk about capsular contracture. So whoever's listening and had a question about capsular contracture, we will talk about that coming up when I talk about implant-based reconstructions. That's definitely something to consider. So the most important thing is really, you got to know your options, right? And it's best to know it before your cancer surgery, but it's never really too late. But knowing your options can really help you lay out your plan going forward, and it can bring some peace and calm to you because you kind of have a set plan. A lot of folks I've met have kind of gone into their breast cancer surgeries and their reconstruction kind of being told what they're going to have and not really given a lot of options. And later on, if there's an issue, they talk to me and they say, oh, I wish I knew there were the other options available. So just know your options. And honestly, as a surgeon, you know, everyone says, oh, surgeons don't want you to go get second opinions. That's just not true. I think getting a second opinion is always a good idea. So if you're not sure, if you're not about what the conversation you had with one of your surgeons, including your plastic surgeon, go talk to another plastic surgeon and ask for what they think are your best options. So your breast reconstruction options, and all the pictures I show are come out of our practice. One, and the most common, is the use of an implant. Another is called flaps, which uses tissue from another part of your body to build a new breast. Or you can kind of combine the two concepts together. Use tissue from your body as well as an implant. And then what we call oncoplastic surgeries. So the first three that I just talked about, implant, flaps, and the combination of the two, are really for mastectomy situations where you've lost the entire breast. But oncologic plastic surgery is actually a large growing field that I think has been underreported or under explained to the population, which is when someone has a lumpectomy or a limited mastectomy, oftentimes that actually leads to still some deformation or change to the shape of the breast that is not aesthetic. A lot of times, if at the same time as the breast surgeon who does the lumpectomy, a plastic surgeon can be there to actually fix that or add volume to the area that's missing, additional procedures down the road can be mitigated or completely eliminated. So that's what we call oncologic procedures. In some patients who have large breasts, they can get a breast reduction at the time of a lumpectomy, and a plastic surgeon would be the one doing that breast reduction portion. So you can get smaller, perkier looking breasts and your lumpectomy at the same time. I think I have a question. Excuse me. Got it. So I'm being told because of our before and after pictures, Facebook is going to toggle us on and off because of censoring. So when I'm out of the before and after pictures, we'll restart the Facebook. And then ultimately, there's nipple reconstruction. For those who lose their nipples, you can reconstruct the nipples, and I'll show you how that's done later on. So let me see if I can restart that. How do I restart that?
Just have go to the so continue. You can just exit out of that and then go to the side.
Going back here.
Just click on the same. Just to make it bigger. Maybe click on that one, yeah. Not that one.
Or you want to go full screen?
Yeah.
Excuse me.
Oh, it's because you're sharing your screen. Yeah, here we go. More. Live on Facebook. And then you'll just. Yeah.
We are back. So when it comes to implant-based reconstructions, well, what is that? First of all, implant-based reconstructions are reconstructions of your breast that uses a silicone or prosthetic implant. And there are different ways to do it, which is one way you may have heard, which is not a lot of people are good candidates for that. And the idea that a direct-to-implant, which is a one-stage reconstruction, will be your last surgery is not really correct. A lot of people end up having additional touch-up procedures to help improve the shape and overall outcome of that reconstruction, because there are a lot of considerations going into a reconstruction. Sometimes direct-to-implant is not the best way to go. Oh, okay. All right. 1 second. With an expander space reconstruction, basically that same implant that's going to be your permanent breast shape, that happens in the second surgery. In the first surgery, instead of with the directed implant, which uses that permanent implant in the first stage, with the expander-based reconstruction, you're putting in a balloon basically that gets expanded over time. What that balloon allows you to do is actually stretch the skin out as needed, because with most reconstructions or most mastectomies, there's some loss of skin and the nipple and areola is removed. And so you need to work against that and help reshape that skin to accept an implant. And so for a lot of implant-based reconstructions, most of them first start with an expander. And anywhere from 3 months to years later, depending on whether you need radiation or chemotherapy, the expander then comes out and a permanent implant is placed. And we'll talk more about that or show pictures of that. Again, a 2-stage reconstruction is the most common form of breast reconstruction. Give me 1 second. It looks like Facebook, you said, is being interrupted again. So how do I stop?
Just go back to Zoom, the big screen again.
Okay.
And then stop live stream. And then you click that. This part, you're going to click show on a page you manage. And then click down to the second.
Okay. Turns out I was the second time I was sharing it in my personal Facebook. So this is why I had somebody else set it up, and when I do it myself, that's what happens. Okay. I'm sure my parents love seeing that. Let's see here. All right, we're going to be going live again on Facebook. Go back to sharing my screen. Okay, now we're back to the appropriate feed for Facebook. All right, so again, a 2-stage reconstruction with implants is the most common form of breast reconstruction, because the most common form of mastectomy right now is still skin-sparing mastectomy for various reasons. And so oftentimes we have to, like I said, reshape or stretch out that skin to accept an implant and have it look more natural. And to do that, you need to put that expander in first, that balloon in first. Then at a later time, take out that expander and put in the permanent implant. So it is the most common form of breast reconstruction. And we just talked about all this. Now, typically in that second stage, when you take out that expander and put in that implant, there are other things that you can do at the same time. You can make small adjustments. You can add fat, called fat grafting, which is a critical part of my practice, and I'll go into that as well. And all those things can be done in that second stage. So what are the advantages and disadvantages of having an implant-based reconstruction? Well, one of the obvious advantages is that it's a shorter operation compared to something like a flat procedure. That's where you use your own tissue to build a breast. It's a shorter operation. It's a shorter recovery time. And usually you're only left with that single scar from the mastectomy versus other scars on your body for using the tissue from that portion of the body. Disadvantages. Well, there are complications related to having an implant that you wouldn't have to deal with or worry about if you did a flap, for example. One question that was brought up was capsular contracture. Anytime there's a permanent implant placed in your body, it doesn't matter if you're getting a knee replacement or whether you're doing breast reconstruction, every time there's a permanent implant placed in your body forms a scar shell around it, a capsule, they call it. And that capsule, for vast majority of women, over 80% of women, it doesn't cause a problem. But in 9 to 10% of women, that capsule may feel firm, and in less than 5% may feel uncomfortable. And that's called capsular contracture. And there are definitely things you can do in what we call revision surgery to help remove that entire capsule and release that capsule or remove that capsule to help with the shape again. I'll actually show you some before and after pictures of revision surgery that addresses capsular contracture. But having implants does come with it dealing with the fact that you have an implant, which capsular contracture, potential rupture of the implant. Now, rupture rates are very low on implants. They're less than 1% per year. So 10 years from now, the rupture rate is 10%. So that's a lot lower than they used to be. And that's because the new implants are more form stable, and they are just more durable than the old implants were. Radiation increases the risks of these things, especially capsular contracture. So if you know you're having radiation ahead of time, having an implant-based reconstruction doesn't mean you can't get it, but you need to know that it increases your risk of things like capsular contracture when you get an implant-based reconstruction. But again, there are techniques to help mitigate or decrease the complication rates and help improve the aesthetic outcome of your reconstruction. Okay? The tissue expander process takes time, but usually it doesn't really delay things beyond what you would normally do waiting to heal from your first surgery. The shape can look a little less natural than a flap or a tissue-based reconstruction. And the opposite breast, if you have a one-sided mastectomy, the opposite breast, which is still your natural breast, will now have a different, more natural appearing shape than your reconstructed breast. And oftentimes because of that, we do what we call a symmetry procedure on the other side, which typically involves a lift, and sometimes maybe even putting an implant on that side, basically getting a lift and an augmentation. So with bilateral, meaning both side reconstructions with mastectomies, you tend to get a more symmetric result with implants than you do with a one-sided mastectomy with implants, because the other side is natural and will behave differently, even though you can do symmetry procedures to make it look more similar to the reconstructed breast. Here's an example of tissue expanders. This is the balloon that I was talking about. This was what goes in immediately after the mastectomy is performed. I'm not getting that one. Sorry. Oh, thanks. And with tissue expanders, typically they're placed in either partially inflated or not inflated at all. And you later on, after you've healed for a couple weeks in the office, these are expanded in the office with salt water or saline. Excuse me. It's not a painful process, and it's a 5-minute thing. This is how it's done. It looks like it should be painful, but it's not, because remember, after a mastectomy, the sensation in the skin is essentially gone. You have numbness there. So there's no real pain often associated with this. This is what we call dermal matrix, and I'm going to just move on to the next one, or maybe what I'll do is I'll pause my Facebook live stream so we don't get banned again. 1 second. This is what we call acellular dermal matrix, and it's really changed how good of a result you get with breast implant reconstructions. And the reason for that is, in the old days, in order to reconstruct the breast with an implant, they used to put implants immediately underneath the skin. That caused a huge number of problems because the skin, mastectomy skin, couldn't handle the weight of an implant. So then they started putting implants underneath the muscle layers, the pectoralis muscle and some of the other muscles. But things looked really tight. And so what they came up with was acellular dermal matrix, and that's typically skin donated from patients that have passed, that is used in combination, either on its own or in combination with muscle, being under the muscle, to create a more expandable pocket from the very get-go. It still supports the weight of the expander or the implant without putting pressure and weight on the skin, which is what caused the issues initially. But now, because it can change the shape in the lower portion of the breast and let it expand more, it gives you a more natural shape. So the use of dermal matrix is about 100% in all my cases. And in cases where we're not putting any implants underneath the muscle, we're putting it all entirely on top of the muscle, it's a must. And I'll go into the differences between having an implant underneath the muscle or on top of the muscle shortly. But here's an example of a tissue expander reconstruction. What you're seeing here is a patient that is before surgery. And then the next picture is them with tissue expanders in. As you can see, it does not look natural. But these are tissue expanders. They're not designed to look good. They serve a purpose. They hold space or stretch skin as needed. This particular patient wanted to be a little bit bigger. So during the process of fill, we made her slightly bigger than she would have been if we hadn't stretched her skin out. But as you can see, it doesn't look very natural, but that's not what she's going to look like. Ultimately, those expanders get removed and implants are placed. And in this situation, this is her true before and after. You can see that she has a good transition in her upper part of her breast, and the shape is nice and symmetric. And the reason it looks pretty natural compared to the expander on its own is, one, the implant is a lot softer than the expander. Remember that implant, the permanent thing, is a lot softer than the expander, which is the thing, the balloon that holds the space. And two, she's also had what we call fat grafting, which is fat that's been removed from a part of your body through basically a tried and true technique called liposuction. And it's using small cannulas. That fat is then placed into an area that you do want it. In her case, it was placed into the breast. And the reason we do that is because after a mastectomy, the skin is so thin. The skin is so thin, it makes anything you put under it very visible. And so what the fat allows us to do is help thicken that skin and help shape and contour the breast even more so than what an implant could do on its own. Here's a patient who did not have a nipple-sparing reconstruction who wanted to be larger. And you can see she has what would look like, if she had nipples, what would look like an augmented breast. This was a two-stage reconstruction. Here's another example of one who did not have her nipples saved. She had what we call skin-sparing mastectomy, but had a nice reconstruction afterwards. This is what we call that single-stage reconstruction, or the direct-to-implant reconstruction. The patient had an incision created down here in the bottom portion of the breast by the breast surgeon, and instead of going through the process of an expander and then followed by an implant, the implant was placed immediately during this stage. This can be a good option for some patients, but you typically need to be a nipple-sparing mastectomy, and you need to have certain breast shape and size ahead of time. It's not great for patients that are small-breasted that want to be larger. It's not great for very large-breasted women that may need a reduction of their skin, and it's usually reserved for those who are nipple-sparing and are not going to have potential radiation treatment afterwards. We talked earlier, and someone asked a question about capsular contracture. This is a patient on the left who had bad capsular contracture. By removing that old implant and the entire capsule, the entire contracted capsule on its own, and combining it with use of dermal matrix, that acellular dermal matrix we talked about earlier, ADM, as well as fat grafting and a smaller implant, you can give her a more natural, softer looking shape, breast and shape. This is a patient of mine who had 6 breast surgeries by 5 other plastic surgeons. And she constantly had recurrence of her capsular contracture. But what I found out was they were all doing the same thing. And what you can do are, instead of just removing the capsule, you can, again, use that dermal matrix and fat grafting, which has been shown to decrease your chances of getting capsular contracture and get back to what looks like a more normal breast and shape. Now we're getting into flap procedures. So flap procedures are the reconstructions that you do using your own tissue. Now I'm going to stop here for 1 second because I want to start resharing this on my Facebook. Hopefully not my personal one. So we're going to go back. So now we're talking about flap procedures. Again, these are reconstructions using your own tissue. And using your own tissue could mean including your muscle, skin, fat, and sometimes the blood vessels to reconstruct the breast. Okay. Where the tissue is taken from, we usually call that the donor site. And that donor site can be anywhere from your belly, your butt, your inner or outer thighs, or sometimes your back. And there are different kinds of two different kinds of flap procedures in general. One is a pedicle flap, which is where you take the tissue from, the blood supply to that tissue is maintained, and things are swung around or placed into the breast area without disconnecting the blood supply. The newer techniques called free flaps, those are where you actually disconnect the blood supply to that tissue from that donor site, most commonly the belly, and you reconnect that blood supply through microsurgery where the breast is going to be, and that's typically in the chest. I'll talk more about that. One of the pedicle flaps we just talked about, not the ones where you disconnect, but everything stays connected, is a Latissimus dorsi flap. It's a pedicle flap. You can rebuild it. You can rebuild the breast. We're using it on its own, but it usually has limited size if you try to use it entirely on its own to rebuild a breast. But oftentimes it is used in combination with an implant. So why would you do this and an implant? Well, in the old days, and we still do this, when there was radiation, whether it was known ahead of time or maybe something that needed to be done after the fact, adding this flap helped get a nicer, more robust reconstruction, one that is less prone to some of those issues with radiation and implants. Nowadays, with use of Dermal Matrix, which I spoke about earlier, that donated skin, as well as fat grafting, the use of Latissimus dorsi flap as a way to mitigate the effects of radiation has become less important. And so it's one option and one operation that I'm not doing much of anymore. But it is still an option as a bailout or a secondary option for a lot of folks. Again, it comes from the latissimus muscle as well as potentially the overlying skin above it. And what that is done is you wrap around, or you remove that tissue and you wrap it around and bring it to the front and use that extra tissue to reconstruct the breast. Here are examples of patients who had only the muscle used, no skin part, only the muscle used to add to the reconstruction. And this was likely because this patient needed additional tissue or was going to have radiation. A tram flap, which is similar to another flap we're going to talk about, which is called a deep flap, takes tissue from your stomach and uses it to reconstruct your breast. And it keeps the blood supply connected, because this is also pedicle flap, and it rotates it up and places it where you need the extra tissue. This is a kind of an older version of what is called now the DIEP, or deep flap, which does not keep the blood supply connected. It disconnects it and reconnects it in your chest. And by doing so, it does not sacrifice any portion or significant portion of the abdominal muscles. Whereas with the tram flap, this one, actually there's a morbidity associated with it in the sense that portion of your abdominal muscle needs to be used for this reconstruction, and you will no longer be able to use it as part of your abdominal musculature. So free flaps, that DIEP flap that I talked about, along with other flaps, are the ones where you detach the blood supply and reattach it where you need to reconstruct it. The advantage of this is that it can often have a very nice, natural, good-looking result that is fairly resistant to radiation and some other things compared to implants. However, with newer techniques and implants and fat grafting, that difference in the results or the aesthetics of the results is really becoming less and less. Again, the advantages of it is the naturalness of it and the lack of an implant, but the disadvantage is that it's a much longer surgery and it's a longer recovery time, and there are other considerations and potential complications associated with the donor site, that is where you take the tissue from. So what do I mean by a longer surgery time? With a implant-based reconstruction, you're looking at additional 1 to 2 hours on top of your mastectomy surgery. Whereas with this surgery, if it's both sides that need to be reconstructed, you're talking potentially anywhere from 6 to 12 additional hours of surgery. And instead of going home the next day, you may be spending the next 4 to 7 days in the hospital. So that's one obvious upfront difference. The donor site, or where you take the tissue from, that's an additional consideration. So scar, where you took the tissue from, in a belly, it's not so bad because it looks like a tummy tuck. And if you have extra tissue, it's actually good. But there's also the fact that you're going through the abdominal muscle. So there's a small risk of hernia or a bulge in your abdomen after this surgery. But overall, it's a very safe surgery, and it has a high success rate, and a lot of folks choose this. But it's still by far less common than implant-based reconstruction for those reasons that we just talked about in terms of longer upfront time, longer recovery, and some people just don't have enough tissue to donate, or they don't want to go through that recovery time. This is an example of how a DIEP flap can look pretty darn good. This is a patient who did not have reconstruction initially and went on to have what we call a delayed reconstruction. This is a patient who had a similar procedure, but instead of a deep flap, where it comes from the abdomen, this is a tug flap, which comes from the inside of your thighs. My favorite thing is fat grafting. And the reason I love it is, well, twofold. My patients love it because they get liposuction. But they also love it because it can really hone and improve the appearance of the breast during your second stage of reconstruction. And what I mean by that is, as you saw in an earlier picture, the breast skin is very thin after mastectomy. And when you put an implant underneath there, it can be visible. You can get rippling, you can see the implant. And the way you get rid of that or make it less is by thickening the skin. And the way you thicken the skin is by adding volume to that fat layer. And where we get that fat, anywhere you want, your back, your stomach, your inner thighs, process the fat during surgery and put it right back into the breast skin to help thicken the skin and give you a better shape and less visibility to the implant. And that's and there's some studies now suggesting that it helps decrease the effects of radiation and mitigate those negative aspects of it. You can use fat grafting by itself in certain situations. With lumpectomies, if there's a deficit where the fat used to be, and now, or the breast tissue used to be, you can fill that in with fat grafting. If you have very small breasts and want to have very small breasts after mastectomy, you can do fat grafting. Even B-cup size breasts you can create with just fat grafting with no implant. And this is different than the flaps that we talked about earlier, which require incisions and removal of the blood supply and just reconnecting the blood supply. This is totally different. We're talking about liposuction and taking that fat and using needles, injecting it back into the breast area. It can, like I said, improve the appearance of radiated breasts. It can help with the visibility of implants and the rippling. And you may require, for an implant or even a flap procedure, may sometimes benefit from fat grafting. If you want to go significantly larger, you may need more than one procedure, but for most, they can get a significant improvement with just one session of fat grafting. And I personally do it in about 100% of my cases. This is what I was talking about when I said a lumpectomy. You can have a dimpling or scarring after a lumpectomy. And a lot of that has to do with the radiation too. That can be improved with fat grafting. This patient with one session of fat grafting not only released that scar that was there, but filled in that deficit of volume. Doing that not only made the shape better, but it improved the appearance of her nipple as well, because everything that was pulled away due to the lack of volume and scarring has been popped back out, and she's very happy. This is a patient that wanted reconstruction just with fat. And I believe this patient had 3 rounds of fat grafting and achieved a small B cup breast through just fat grafting alone. Finally, for a lot of folks who don't get nipple sparing mastectomies, they may want a nipple when it's all said and done. So when you're happy with the shape and size of your breasts, and now you just want nipples, that's when you do a nipple reconstruction. It's kind of like the cherry on top. It's a vast thing that you do. And the way you do it is you actually, for lack of a better way of saying it, you origami the skin on the breast tissue, on the breast, into a little cylinder. And once that cylinder heals, you get medical tattooing of what looks like a 3-dimensional nipple. Now that's actual nipple reconstruction with tattooing. But a lot of folks are just opting to get a 3D tattoo. A 3D tattoo looks 3D, but there's no 3D component to it. There's no actual nipple reconstructed. So you have plenty of options when it comes to nipple reconstruction. They can look pretty effective and pretty good. Ultimately, the whole point of reconstruction is for you to gain control of what's happening to you in terms of your journey through the cancer treatment. You can control how you can build your breast back up. One of the things I tell all my patients is, with this expander in, for example, you tell me when you're the size you want to be. We don't have to do one particular size. You don't have to agree to implants. You don't have to agree to the size of the implants. You don't have to do a microsurgery flap. I will give you the options. We'll go through the pros and cons of it, and we'll figure out what makes sense to you. If an implant-based surgery is better for you because you want to get back to work faster, and you have, you don't worry, and you worry about being in the hospital for 4 to 7 days, we'll do an implant-based reconstruction. If you don't want to have an implant, no matter what, we can do a tissue-based reconstruction. You need to gain control, and one of the best ways to do it is to know your options and demand from your reconstructive surgeon to give you all those options and see which one's best for you. Okay, so what we're going to do this is my partner, Leif Rogers. He helps me on a lot of my cases, especially the bigger flap cases. And we have 2 locations, one in Beverly Hills and one in Pasadena. Those are our number. What I'm going to do now is open it to some questions. I'm going to stop sharing my screen. And can everybody see me? Let's see. All right. And I'm going to start sharing from Facebook again. Oh, I guess I was. Oh, it didn't kick me off. All right. Good. All right. So let me see. Let me see if to everyone. So I'm opening up my chat, and we're open to questions. You can chat with me through the Zoom. For the folks who are in the Zoom, they can chat with me through there, or they can unmute themselves, or the facilitator can potentially unmute them if they raise their hand. And if they have questions coming through Facebook, I can also get it from my assistant Tally, and we'll answer those questions. So, first question.
Okay.
Yes.
Can you hear me?
I can hear you.
This is Martha. Can you hear me?
Hi, Martha.
Can you hear Martha?
I can hear you.
Okay, great. I just wanted to know, I want to have reconstruction because I had a mastectomy, and it's probably with fat grafting, but the other breast is not going to look as nice. Do you do both?
Yes. So not only you can do both, but both should be covered by insurance. The second breast, even the one that didn't have cancer and didn't have cancer surgery, can get what's called a symmetry procedure, and that is covered by insurance.
Mute.
Great. That is good to know. Thank you.
All right.
Are you seeing
Yes, go ahead.
patients right now?
Can you repeat that? Yes.
Oh, I'm sorry.
Is
Is your office open to see patients?
Yes. So right now, in-person consultations are limited. I am seeing a lot of my breast cancer patients in person that need immediate attention, but I am running a lot of virtual consultations, which I can help you set up. And what we'll do is, with a virtual consultation, we can go through a lot of the stuff that we talk about anyway. We can do a visual exam, and then in the next couple weeks, we should be able to actually schedule in-person consultation as well.
Okay, thank you.
Of course. Tara, let me see if I can unmute you. Go ahead. Wait, hold on. Don't go ahead. It's not working. How do I unmute?
Unmute now. I got it.
Okay, there you go.
Hi.
Hi.
So my case is, well, it's not really complicated. It's I was diagnosed 2018. I had a partial mastectomy.
Sorry. We're still on Facebook in case anybody doesn't want to share on Facebook.
That's okay. Partial mastectomy. I had a lift and reduction at the same time. Went through chemo and radiation. I was told that was just preventative, and was fine for a couple months, and then was re-diagnosed last September.
Okay.
So going through chemo, I went through chemo and a little bit more now with infusions, and it seems to be the tumors are shrinking. I had 5. So I just had my PET scan yesterday to see what the progression was and see what's happening. But they're telling me that I should really have a mastectomy. That's the end goal of this. Okay. So I've been on the fence of whether to have just a mastectomy and be done with it. City of Hope doctor says you just have to have one side done. I'm thinking have both sides done. But now I'm really on the fence, especially after hearing your presentation of just going forward with the reconstruction. So, because I mean, the photos that you showed were very, very helpful to me to see really what I wanted to kind of move forward with. So, but I don't know if the fat grafting seems a very good way to go. I think a 38 double D, and when I had my lift and reduction, I'm like a 36C maybe now. Like, it's fantastic. Yeah. But now I'm having to think about losing them now that they look so great.
Well, that could actually, the silver lining. The silver lining is that even though you may not need a reconstruction, a full mastectomy and reconstruction, having large breasts with a mastectomy creates its own issues in terms of needing to do a lift and a reduction of the skin of some form or shape, either during that initial mastectomy or later on, right? You've already had that now. So the silver lining is the shape that you have that's better now, and the size that you have that's better now, is something that we kind of don't have to worry about as much. And after that, and with that mastectomy, you're also probably less likely to have wound healing issues, believe it or not, because of the previous surgeries that you've had. It affects their blood flow, so your body kind of adjusts to that. And now you can have a reconstruction that's more like somebody who has a C-cup breast that doesn't need to have a lift and a reduction because you've already had it. And so the silver lining here is that you're likely to get a nice result from a total mastectomy and a reconstruction now that your breasts aren't as large. So that's okay. Fat grafting is good, but I caution against doing fat grafting in a situation where you had recurrence of disease and people are recommending, your breast surgeon's recommending a mastectomy. I personally am not in the business of recommending a lumpectomy or a mastectomy. I leave that to the oncologic breast surgeon, right? But I know enough to tell you that in this particular situation, I prefer not to do fat grafting in a breast that's had a recurrence. I prefer for you to have that mastectomy and get it reconstructed, and you can still get a nice result that way. It's a longer process, it's a longer road with the mastectomy, but I think your risk is going to be reduced, as your breast surgeon will tell you, will be reduced more if you do the mastectomy.
And then my second question, I'm sorry I'm taking up so much time, is that I'm just under the assumption that I should just have them both done, like just take them both, because I don't want it to recur in the right breast. All the trouble's been in the left.
Yeah. So the choice to remove both breasts often, not always, but often comes down to a personal choice.
Mhm.
Many people are getting both breasts removed, even though the numbers say they only need to remove one breast. Personally, as a plastic surgeon, and I'm just literally just wearing my plastic surgeon hat right now, I'm not even talking about cancer risk. I would rather you have both breasts removed from a symmetry standpoint. If I'm going to employ any reconstruction technique, doesn't matter if it's a flap, if it's fat grafting, or if it's an implant, when it's both breasts removed, you're more likely to have a symmetric result than having to deal with one natural breast and one reconstructed breast, which I do all the time. And
Yeah.
I tell folks who are having bilateral, both-sided mastectomies, my goal is for them to be as symmetric as possible. I tell folks who are having a single mastectomy with reconstruction that my goal is for them to look similarly shaped and sized in a bra. Because in a bra, the natural breast is being lifted up and creating a nice cleavage up top with the natural breast. With the reconstructed breast, you oftentimes don't need a bra. You have fullness up top and you already have cleavage, and it's not going to drop so much. And so when you reconstruct a one-sided breast, oftentimes the goal is, in a bra, do they look like two similar breasts or symmetric breasts? And that's usually my goal with one-sided mastectomies. It can be done. It can be done nicely. And you can get good results with a one-sided reconstruction in a bra. But oftentimes, especially down the road, the natural breast will tend to droop more than the reconstructed breast.
Thank you so much. I appreciate it.
Of course, no
Hi,
problem.
Meg. I think John wants to ask a question.
John, go for it.
Hello, Dr. Nima, how are you?
Good, how are you?
Good. I'd like to tell everybody just how terrific you are. Fantastic for Meg, along with Dr. Rogers.
We love you guys.
One of the things that you really did not touch upon tonight is part of Meg's journey, which is somebody who's had a diagnosis of breast cancer, had a lumpectomy 10 years ago, has a recurrence
In the same breast.
in the same breast, and then and the doctor recommendation, the breast oncologist, is to take both breasts. One of the issues that we've dealt with, Meg, is infections.
So talk more about that. So infection is a big deal, and infection is a bigger deal in implant reconstruction than it is in tissue-based reconstruction. When you do tissue or flap-based reconstruction, an infection can still happen, but it doesn't typically threaten the reconstruction as a whole. You deal with it through the way you would dealing with an abscess in a normal part of a body, which is you drain the infection, you put the person on antibiotics. It may affect the appearance of the breast a little bit. It may increase the amount of scarring, but at the end of the day, the vast majority of the shape and volume is preserved. With an implant-based reconstruction, if there is a bad enough infection, what can happen is one that doesn't go away with just some antibiotics. What you will likely have to do is remove that reconstructed implant, the breast, not remove the tissue, but the breast implant. Once you remove the breast implant, you have to allow that tissue to heal. You get the antibiotics, and then you can come back and restart that process. It is a lot of folks don't want to have to deal with that. And the risk is higher if you've had radiation in the past. So if you've had radiation in the past, it doesn't matter whether it's an implant or a flap, your risk of infection is just going to be higher. And the reason for that, and thanks for bringing this up because it also lets me talk a little bit more about what radiation does. Radiation kills blood flow and blood vessels in tissues. It makes tissues stiffer with less blood flow. So radiation increases your risk of poor healing or not healing. It also increases your risk of infection, because how does our body deal with infection? Through white blood cells in our blood. Well, if the blood's not getting there like it normally does, your risk of something that would normally not become a problem increases into something that could become a problem. And then when you don't have enough blood flow, and you're trying to deliver antibiotics, it also doesn't work as well. So in the setting of an implant and radiation, an infection often means removing that reconstructed implant, the breast, and letting it heal, clearing the infection, and literally hitting the restart button. I think the risk is about 2 to 3 times higher in a radiated breast than it would be in a non-irradiated breast. And it's, of course, a bigger issue with an implant-based reconstruction than a tissue-based reconstruction. But the rate of infection in non-irradiated implant-based reconstructions is quite low, I believe it's less than 5%, generally speaking. With a radiated breast, it's higher. It's 20 to 30%. And the rate of revisions needed on a radiated breast is 50 to 75% compared to 30% in non-irradiated breasts. So radiation creates a huge issue with the appearance and your ability to heal. And that's something I wish I didn't have to deal with as a plastic surgeon. I wish nobody had radiation, but that's not my decision. My job is to just deal with the hand that's been dealt.
And if you've dealt with kind of recurrent infection, would it be your recommendation to go to the flap?
Yeah, so if the problem is repetitive infections, you have to see why there is a repeat of infection. So, for example, if there's redness and you feel there's infection and you just put the person on an antibiotic and it seems to get better, but then as soon as they come off the antibiotic, it gets red again and the infection comes back, you haven't done enough. You have to do more than just put them on an antibiotic. And that often means going in there and removing that implant. But if the implant has been already removed and all the dermal matrix and all the capsule has been already removed, and you still have recurrence and issues with infection after the fact, before the implant has been replaced, by the way, you have to have, in my opinion, a period of no infection and everything kind of healing and looking fine before putting an implant back in, right? And so personally, I haven't experienced somebody having continued continued infection issues after the implant has been removed. Every patient I've ever had a problem with infection once the implant was removed and all the capsule was removed, then they were able to clear that infection. Once that infection has been cleared and the tissues relax and the inflammation wears off, that's when I start entertaining the idea of going back and either putting in a tissue expander or an implant or talking about a tissue-based reconstruction. I think repetitive issues with infection after the implant has been removed, healed, and then another infection with the second round is a good cause to talk about doing tissue-based reconstruction.
Okay, finally, one last question. Could you do a tiny touch on me?
Stop it. Okay, turn your mute. You know how to mute? So, can I have a question? I have a question.
I'm muted.
Okay. What's the difference between a tram flap and a deep flap?
Great question. So the original deep flap was a tram flap, and the tram flap was it is where they take tissue from your stomach and you rotate it up into the chest, but you keep the blood supply connected. And the way you do that, you actually sacrifice one column of your ab muscles, of your six-pack. That stays attached to that tissue, and that gets pulled up with it. So you have a missing half of your abs when you do a tram flap. Most folks don't do those surgeries anymore. And the reason is it's a little morbid to lose a whole row, a whole column of your abdominal muscles. And it tends to look a little less natural, and you get a little bulge right where that muscle is kind of crossing over here. the evolution of the tram flap was a free tram and now what's called a deep flap. And the difference between a free tram and a deep flap is just how much of the muscle is being affected. But instead of sacrificing the entire abdominal muscle column, what you're doing is actually dissecting meticulously through that muscle and just isolating the blood vessels, disconnecting that blood supply, taking that tissue in here and reconnecting it into the chest through removal of a segment of the rib in the chest, and you connect those blood vessels through microsurgery into the chest blood vessels. The muscle at that point, with the deep flap, is less, it's not sacrificed, and it's less injured, and it has lower morbidity compared to a tram flap.
Thank you.
Of course.
I'm doing a deep.
Good.
So excited.
Do we have? Sorry, one Facebook question. Okay.
She said, for a C cup, can I have just fat grafting? How many sessions each?
Okay. So the question from Facebook is, if I have a C cup breast and I need that reconstructed, can I just do it with fat grafting? The answer is probably. It comes down to a couple of issues. For one, the droopiness of the tissues. If you have fairly small but perky C-cup breasts, you can probably reconstruct that with just fat. However, it will take several sessions, anywhere from 3 to 5 sessions of fat grafting, and that's a minimum. And so for C-cup breasts, especially folks who would really rather not have an implant, I often say, would you be okay with a B cup? Or if you have to have a C cup, why don't we still do as much fat grafting as you're willing to do and go with a much smaller implant? So, because the volume of the fat is going to basically subtract from the volume of the implant that you would have put in. So you can go with a much smaller implant, get a nicer looking, more natural shape, and do most of it with fat. So the question is, can you do it all with fat? Probably, but it'll take a lot of sessions. A lot of folks may not want to go through those many surgeries. Some do, some have, but most usually go with just a smaller implant and just a couple rounds of fat grafting to make it look nicer and more natural.
She asked, will she get capsular?
The follow-up to that question, the patient is asking, well, will I get capsular contracture? I can't predict who's going to get capsular contracture, but what I can tell you is that if you've had radiation, you're at higher risk of capsular contracture. What I can tell you is that if you use Dermal Matrix for your reconstruction, which I do in 100% of my cases, Dermal Matrix has been shown to decrease the risk of capsular contracture. And personally, anecdotally, I think fat grafting also further reduces that risk. So capsular contracture, significant capsular contracture, has not been a huge issue in my practice with my patients that I start off on their own, like from the scratch. I have a lot of patients who are revision patients who have had their reconstructions done at a previous time, maybe before Dermal Matrix or maybe before something else, who do come to me for capsular contracture. But capsular contracture has not become, at least early on, a big problem or complication with the newer techniques that we're using, with the new materials that we're using, which is a Dermal Matrix. Tara? Is it Tara or Tara? Either one? Okay, go ahead.
I've been either one all my life, so I will answer to both.
Okay.
Do you only do surgery in Pasadena or Beverly Hills? Or do you do surgery at do you have privileges at other hospitals?
Yeah, no, those are just my offices. I have privileges in terms of for reconstruction as far west as Beverly Hills and as far east as Arcadia Methodist. And coming east to west, it's Arcadia Methodist, Huntington Memorial, along with some surgery centers here.
In the Valley?
In the Valley, Glendale Adventist, Burbank, Providence, St. Joe's in Burbank.
In Tarzana.
In Tarzana, not in Tarzana. I think probably the
Okay.
closest one to you that I have privileges would be Providence, Burbank.
Okay, I'll have to, because I'd love to come in and see you. That's that's a separate thing. But I have two sets of doctors. First is the Cedars-Sinai umbrella, which is in Tarzana.
Mhm.
And then the second is City of Hope.
Right.
So,
I used to operate out of Cedars as a private practice, not as part of their umbrella. But I just my practice, and as well as St. Joe's in Santa Monica. But I've kind of focused a little bit more from. There is a separate surgery center I work at now in Beverly Hills. Just makes it easier to do cases there. But I'm happy to. I think initially, maybe probably the best thing for you, because you're a little bit further out, is just do a virtual consultation with me, and then if if you want to proceed, then come in and we'll talk even more, and we'll make it
perfect.
as convenient.
Perfect. Yeah, we'll know more after the results of the scan came back. They put a rush on it, so we
Sure.
should know in the next couple of days. So,
No problem. Of course.
thank you.
Okay, so the question, I have another question related to capsular contracture. Capsular contracture, again, is that tightening or hardness and thickening of that scar tissue around implants. The question was, do you recommend taking Singular afterwards? So there's some limited evidence to suggest that taking Singular, which is an allergy medicine, can help reduce or maybe even improve the risk of capsular contracture. But it's not that effective. The more effective drug is actually called Accolade, ACCOLATE. It's similar to Singular. You may want to get liver function testing while you take it if you're concerned about your liver. But that's been shown to have a little bit greater efficacy than Accolade. And for folks who've had a history of capsular contracture, that's something I would look into and recommend, but I don't routinely prescribe it to everybody. I don't think it's necessary. Plus, the effect of Accolade or Singular in reducing your risk of capsular contracture is small compared to the effect of using Dermal Matrix and fat grafting in reducing your risk of capsular contracture. The question, I just got a question. What is the cost of a virtual consultation? If it's a cosmetic, there's a cost. But if it's not cosmetic, if it's for breast cancer related things, what we do is we ask you to just give us your insurance information, and we will run it through your insurance, and there shouldn't be an immediate cost out of your pocket. Any other questions? Any? Let me see. Any other questions? A lot of folks not sharing their camera, their vehicles. I don't blame them. Oh yes. How do I?
Yes,
Ah, yes. Go ahead.
me?
Yes, you.
Yeah, okay. 3 months ago, I had bilateral mastectomy.
Okay.
Yeah, and 2 years ago, I had lumpectomy on the left side. And after surgery, the left side looks awful. It's swollen. It's up, like up to 10, 12 centimeters. And it has dimplings, lumps and bumps and everything.
Mm-hmm.
So, and I still have fever. The first month it was like high fever, and one last month it's just low grade fever, and they don't know where it comes from. So they tried to fill my breast for 50 cc once, but they said they told me to relax and wait until, because it's like stone,
It's very hard. Yes.
Yeah, very hard. Even after 3 months, it's still the same. But right looks good. So tomorrow I have an appointment, and I assume that they will try to do another like 50 cc or something.
You mean with the expander? You mean fill the expander?
Yeah, I have expanders.
Yeah.
What do you think? Should I wait, like, no matter how long will it take, maybe a year, maybe less, until it will become the same and then to continue, because I think that they can do symmetric things, or it's gonna stay like that forever. It's on one of the picture you had that, you know, but mine is awful. She had a little. Mine is awful, you know. I don't know. It will stay forever.
I've seen a lot of what you're describing, and the reason it is the way it is because you said you had lumpectomy. To me,
Radiation.
it's the radiation. Because when I hear lumpectomy, I think radiation, and when I hear radiation, I think tightness, hardness, scarring, and so that will improve with time. It will more so improve also if you do some fat grafting and scar releases, but it will never be as soft and as loose and as stretchy as the other side. It can't. And so a lot of what I do in these situations is splitting the difference, meaning one side is very high, it's very tight, it's too high, it's too tight. So you do whatever you can to lower it, soften it, improve the blood flow to it, because what happens when you do fat grafting is that new fat that takes hold in that tissue creates new blood supply. New blood supply is what you need in radiated breasts. So with new blood supply, the breast tends to look softer, tends to look a little lighter because the skin tends to get dark after radiation, and it tends to soften a little bit. And that's good, but it still won't be quite to the point where you are with the normal breast. But you can get it softer. Time helps, fat grafting helps, and scar releases help. And if you don't do all three, it won't work at all. Because fat grafting without scar release, there's no place for the fat to go. And if you do it when things are too inflamed and too hard, and you haven't waited long enough to do it, to do the fat grafting, you're kind of basically trying to fat graft into concrete. And so you sometimes need to wait. You always need to do some fat grafting and scar release, and you try to give that shape again with an expander. And at the end of the day, if after that you still can't get it to stretch out sufficiently to give you a nice breast shape, then I would then recommend tissue-based reconstruction. Either only tissue or a combination of that flap I told you about, which is called the Latissimus flap, which takes from your back and brings extra skin. Because what happens when it's so tight, it ends up being as if you don't have enough skin. And if you can't get the expander to stretch it, if you can't get the fat grafting to help soften it to the point where it will stretch, then you just need extra skin. And if you're going to the way to bring in extra skin is through using your own tissue. It's worth a shot. It's obviously hard and impossible for me to say in your particular case because I haven't seen you. But just through my experience, depending on the radiation injury, a lot of folks, you can make them better, a lot better, by doing a new expander, expanding it, putting fat in, giving it a little bit of time, and doing symmetry procedures on both sides to make up the difference. If one is down here and one is up here, try to do it like this, right? But there are a few people who are just so bad on one side that sometimes the best way to go is to hit the reset button and bring in new tissue.
So I shouldn't go and fill out like 50-50. So this
I don't
hasn't
know.
worked.
I couldn't tell you specifically because I don't know your case. I haven't seen you. But if your surgeon feels that they can put in 50 cc's, they can try. It doesn't hurt to try to expand it. It shouldn't cause.
I feel pressure when they did it first and only one.
Yeah.
I feel pressure. That's why they stopped.
Probably because it's so tight. You just have to wait and see. Sometimes with expanding through irradiated tissues, you have to do it slower. You have to do a smaller amounts and slower and give it more time to relax. If it's not relaxing, then you really got to talk about other options.
Thank you.
Of course. Someone asked, what is scar release? Scar release can be anywhere from removing old capsule that has tightened things up to actual scar that's formed from the radiation. And that's usually either done through a surgical approach, an invasive approach, where you go internally and you release or remove the scar, or you can do it what we call percutaneously or minimally invasively with needles, where you actually open up that scar using like a needle to break it down through the skin without having to make a full incision. Usually the best option is the combination of the two, actually. Any other questions from Facebook? Not yet. All right. We are approaching our 8 o'clock end time, but I want to see if there are any other questions. Don't. Yes, John, go for it.
It's me. It's Meg.
Oh, hi, Meg.
Hi. So the skin will come off my. You actually replace the damaged radiated skin with skin from the tummy also. Yeah.
If the choice has been made to go from an implant, what was once an implant reconstruction, but you had to remove the implant, and now you have stiff, scarred down tissue, trying to stretch that out is probably not going to work. And so when you bring in that tissue from the abdomen, you're going to use more of that tissue to replace what would have been the skin up here. In folks who have immediate deep flaps, less so of that flap or the skin of that flap is needed. Sometimes you just make a little circle for where the nipple is going to be, or if it's a nipple sparing mastectomy, then you get rid of all the skin from the belly and you just use the fat. But in a delayed reconstruction where you've had no reconstruction or a removal of an implant or radiation that has scarred things down, then oftentimes the best thing to do is actually just get rid of that bad skin, and you use a good piece of the skin from the belly to actually recreate that. And as you saw in both the deep flap and the tug flap, both of those cases were delayed cases. And for both of those cases, you could see a faint scar that goes all the way across, but the entire lower portion of that breast was actually abdominal skin.
And the success rate on that is?
The typical success rate on a non-irradiated reconstruction with a deep flap is about 95%. Now,
irradiated.
What's that?
What about irradiated?
Well, with irradiated, it's hard to say, and it should still be around 95%. But in certain small number of cases, the vessels, not in the belly vessels, because you've never had radiation in your belly, but the vessels in the chest can be non-compliant. They could be affected by the radiation. If the vessels in the chest have reduced in size, you can often see that in a CT scan ahead of time. But what you can't see is if those vessels have calcified, have stiffened, and have become non-compliant because of radiation. And in those situations, your risk of having blood flow problems is higher, and your risk of failure is higher. And the one downside to flaps is that if there's a problem, it's usually a catastrophic problem, meaning if you can't recover, if you have a problem you can't recover from the issue with the blood flow, you lose the entire reconstruction immediately.
How soon in the recovery do you know whether we have that issue?
75+% of problems happen in the first 24 hours, and almost 100% happen in the first week.
Okay, thank you.
Of course. Great question. Somebody just asked a question, why is the scar with the DIEP so high? So if you looked at the pictures, the scar on that deep flap is higher than what you would see in a actual tummy tuck. And the reason for that is where those blood vessels are in the skin. And you have to adjust where you make that incision based off of those blood vessels. When you're doing a tummy tuck, you put that incision as low as possible because you don't have to worry about the blood vessels. You're not doing a blood vessel procedure, you're just removing skin. With the DIEP, you have to center or position that scar as low as possible, but still within an area that captures those blood vessels that you need. And so it tends to be a little bit higher. I've seen some really high DIEP scars, which I don't agree with. Some of them are way too high. But in general, even in somebody like myself or Dr. Rogers who really know to keep it as low as possible, it still tends to be a little bit higher than it would be in like a regular tummy tuck. Okay. Can the scar be revised? Yeah, if the scar is wide or doesn't look good, you can always revise a scar, whether it's on a breast or an abdomen, and insurance should cover that. Can the scar be lowered? Yes, to a certain degree, but your belly button then becomes a consideration. And what you do with that belly button becomes a consideration. So if it's very, very high and you need to lower it, you probably need to make a new home for the belly button. If it's not super high, but you want to lower it a little bit, you might be able to do that without having to readjust the belly button. Cool. This kind of went pretty well, I think. I mean, there were some hiccups, but it was our first time. But I look forward to doing these more. Okay, so thank you, everybody. In order to contact us, let me actually, you know what, I'm going to share my screen. And what I'm going to do is, instead of can you see my screen on there? So what I'm going to do is I'm actually going to just leave contact information for you guys. Yeah, you can send a message on Facebook, but if you want contact information right now, here's how you can do it. You can email us at info@drnimaplasticsurgery.com. Of course, this looks.
It's just a blank screen right now, just all black.
It's all black. Oh, let me see. I think that'll change in 2 seconds. Let me see. And then, oops, what happened there?
Okay, I fixed it, so you're full screen now.
Okay. And then our phone number, and then our address. I just want to put those in. So we also have the Beverly Hills address, but first give us a call.
Sorry, I still don't see anything.
Oh,
If you're full screen, there's nothing on it. And if we're all in our little Brady Bunch pictures, there's nothing there either.
how about,
You want to put it in the chat?
It came on first and then it went away. I got the 626-537 and then vanished.
got it. Let me just copy paste it into the chat just in case. I put it into the chat, but I'm also going to try to share this screen. Let's see if that works. Do you guys see that?
Yeah, I got it at both in the chat and on the screen.
Okay, great. So that you can reach us at that number, that email address. That email actually goes to myself as well as my office manager. So if you don't hear back from either one of us, then you can blame me. But actually blame my office manager. But the 626 number you should be able to reach. Now, because of our limited hours, that 626 number, the 537-3737, if it goes to voicemail, if it says it's closed and it's normal operating hours kind of, it's probably because we're working on a skeleton crew right now. So go ahead and just try that email address. That might actually be the better way to go. For now. In the next couple of weeks, we'll be back in full force, hopefully, and that won't be an issue. But try the email, I would say, first. But of course, you can try calling. That doesn't hurt.
Thank you so much, Dr. Nima. It was very, very educational and very helpful. Thank you.